be now the HPLC. So HPLC is not again the precisely now. It's been not, we can say, for the advanced technology. We have to go further, GCMS, LCMS, and then other now the things which are coming by the route of the AI that will be used for the detection. Then we will be having the model validation, accuracy testing, cross validation, performance evaluation. Then we have to go for the drug discovery, formulation optimize, PK/PD predictions, clinical decision support. So these are the 4 things which will be useful for us. Drug discovery, then the formulation optimize. As we know, after getting a molecule, then we have go to for the formulation development. Of course, simultaneously we have go to for the toxicity also, for the bioequivalency also. But first thing is we have go to the formulation part. आपके पास एक मॉलिक्यूल आया, आपको डिसाइड करना है कि आपको क्या उसमें फॉर्मुलेट करना है. वेदर यू हैव टू फॉर वी नो द वेरियस डिलीवरी सिस्टम, ओरल में जाना है, ट्रांसडर्मल में जाना है, डर्मल में जाना है, या आपको बनानी है, कैप्सूल्स बनाना है, सिरप बनाना है, लिक्विड फॉर्मुलेशन में जाना है, डर्मा में जाना है, ट्रांसडर्मा में जाना है. तो दिस यू हैव टू टेक द डिसीजन एज ए साइंटिस्ट, एज ए फॉर्मुलेटर. तो यहाँ पर हमारा बहुत अच्छा रोल आता है कि हमें अपना दिमाग लगा के सोचना है कि हमारे पास एक ड्रग मॉलिक्यूल है, इसको हमको कहाँ ले जाना है. तो दैट यू हैव टू डिसाइड. और सबसे पहले तो वी हैव टू थिंक कि इसका कोई कन्वेंशनल है. अगर कन्वेंशनल है तो व्हाट इज द बायोएबिलिटी ऑफ दैट मॉलिक्यूल, क्योंकि सभी की हमें बायोएबिलिटी चेंज नहीं करनी है. ओनली थिंग इज कि द drug molecules, or we can say you're the drugs which are having say 45% or less bioavailability, मतलब 45 से less है, तभी हमको नैनो के बारे में सोचना है. Today what the students are doing, and many of the scientists maybe they are not aware of this, कि जिसके 45% bioavailability ज्यादा है, why we are going for the nano? After all the disadvantages are also there. Not all the time कि we can say कि आप नैनो में कन्वर्ट कर दो. They just see the literature, उसमें से देखते हैं कि किसकी नैनो नहीं बनी, चलो उठाओ बना दो इसकी नैनो. इसका तो है नहीं मार्केट में कोई लिटरेचर. हमने देखा है जब स्टूडेंट स्क्रीनिंग आएंगे तो वी डू आस्क कि आपने लिटरेचर को अच्छे से सर्च किया, जल्दी से मोबाइल से देख के और दूसरे दिन आके बता दिया इसकी तो कोई फॉर्मुलेशन नहीं है तो हम नैनो बना लेते हैं. दिस शुड नॉट बी दैट कल्चर. हमें पूरा लिटरेचर सर्वे करने में वी हैव टू टेक टू नियर अबाउट 2 and 2.5 months टू फॉर कंप्लीट सर्वे. उसके बिना जो आप सर्वे करते हैं दैट इज इनकम्प्लीट. और बाद में यू आर जस्ट लैंडिंग इनटू द प्रॉब्लम कि ये फॉर्मुलेशन तो पहले मार्केट में है या ये इसमें बहुत काम हुआ है. देन यू विल थिंक कि हमें अब चेंज करना है. देन इट्स द प्रॉब्लम फॉर द गाइड ऑल्सो एंड फॉर द स्टूडेंट ऑल्सो. सो इनिशियली उसको स्टेज को हम स्क्रीन करके जस्ट वी थिंक कि हाँ इस पे ये काम हो सकता है. तो यहाँ पर आपको मेनली टाइम खर्च करना है. फॉर्मुलेशन में उतना टाइम नहीं लगेगा जितना आपको इसमें खर्च करना है. सो दिस इज वन ऑफ द माई एडवाइस एज विद द experience I can say to you. So traditional versus AI based. Why we are going for the AI? Why we are going for the nanoculture only? So this the traditional development is time consuming, which I already explained you. Then traditional methods use limited data sheets. Then conventional R&D involves high trial and error costs. क्योंकि जब आपका प्रोसेस लंबा होता है 30 years लगेंगे तो कॉस्ट भी तो बढ़ेगी ना उस प्रोजेक्ट की. सो व्हेन यू आर रिड्यूसिंग नाउअडेज दिस कंसेप्शन इज देयर कि अगर हम ड्रग्स को नैनो में कन्वर्ट करेंगे तो वो कॉस्टली हो जाएंगे. ऐसा नहीं है. ऑन द अदर साइड यू आर if the cost will be increasing by the use of the various excipient which are normally we can say you are the imported one, तो थोड़ा cost होता है. But on the other hand you are reducing the dose of API. ठीक है, एपीआई की डोज कम हो गई और उसका सीधा इफेक्ट हमारी बॉडी पे पड़ेगा कि हमारे टॉक्सिक इफेक्ट या हमारे साइड इफेक्ट्स वो कम हो जाएंगे। तो जब आप टॉक्सिक इफेक्ट्स और साइड इफेक्ट्स कम कर देते हैं तो दैट इज अ मेजर थिंग, और बायोबिलिटी हमारी बढ़ जाएगी। जो आपका अब ड्रग आप सपोज 200 मिलीग्राम में ले रहे हैं, मे बी इट विल वर्क इन 30 mg ओनली। So we have to be screened in a proper way with the help of the proper PKPD, bioequivalence studies also later on. Then we are having the target discovery in hypothesis based in it. हम सोचते हैं कि अब जो हमारी रिसर्च हम करने जा रहे हैं इसमें हमें पॉजिटिव रिजल्ट्स मिलेंगे, जैसे मैंने आपको पहले भी बताया, बट इट्स नॉट जरूरी नहीं है कि आपको पॉजिटिव मिले। बट व्हेन यू आर यूजिंग एआई तो आपको बहुत पहले ही पता चल जाएगा कि आपको इसमें से नेगेटिव रिजल्ट्स मिलेंगे, पॉजिटिव नहीं मिलेंगे। देन इमीडिएटली यू कैन चेंज ऑन योर प्रॉब्लम। Then failure risk is identified late in traditional pipeline. Decision making depends on human judgment. Drugs follow a generalized approach. अब ये नैनो मेडिसिन कंसेप्ट है, तो आई रिसीव दिस मैसेज, तो अभी मेरे को थोड़ा जल्दी करना है। मार्केटेड नैनो मेडिसिन विच आर अवेलेबल टुडे इन द मार्केट, दिस फर्स्ट वन इज द स्नैक 30। I mean, this patent is filed by me only, and this is the US patent, and this product is into the market. This is a curcumin product in which we have increased the bioavailability, and today you will be finding this product in the Amazon or other sites. And this is a very good, product. As we know, the curcumin uses, I mean, many applications are there. आजकल तो इसको पार्किंसन में भी यूज करते हैं, अल्जाइमर में भी कर रहे हैं, डिमेंशिया में भी कर रहे हैं, तो एवरीवेयर द यूज ऑफ हल्दी इज देयर। सो दिस वाज द फर्स्ट पेटेंट, यूएस पेटेंट व्हिच बीन गारंटेड, एंड टुडे द प्रोडक्ट इज इनटू द मार्केट। So other products are there like Amend, this is for anti-emetic therapy, then Rapamune, Sirolimus, this is for immunosuppressant. Then we are having on Petro, this is for nervous problem. Then we are having Toxils, cancer treatment. Then Apaxil, Paclitaxel. I mean, when in the case of the cancer, the most widely used drug is the Paclitaxel and cisplatin. Sometimes the combination is there. So now the Paclitaxel is already in the liposomes form. So I don't have now time to explain why we are using liposome as compared to the conventional dosage form. I'll give you the example. During COVID time, what we have used, जो कि ड्रग की शॉर्टेज हो गई थी बाद में, कोई एंटीबायोटिक थी, कौन सी एंटीबायोटिक थी? एम्फोटेरिसिन सुनी थी, एम्फोटेरिसिन। सो व्हाट वाज द कॉज, शॉर्टेज क्यों हुई? आपको रीजन पता है इसका? एज ए फार्मासिस्ट किसी ने बताया नहीं, आई हैव कंक्लूडेड इट। क्या रीजन था मेन? देखिए, एम्फोटेरिसिन 2 फॉर्म्स में अवेलेबल है। वन इज योर द कन्वेंशनल सिंपल एंड वन इज द लाइपोसोम फॉर्म। ओके, एंड बिकॉज कोविड के टाइम सब नो टेक्निकल पर्सन्स वर अवेलेबल, जो एक कंपनी बना रही है उसके पास भी टेक्नोलॉजी या हम कहें एक्सिपिएंट वो खत्म हो चुके थे, बट एवरी डॉक्टर यूज टू राइट एम्फोटेरिसिन लाइपोसोमिक वाली, प्लेन इफेक्ट नहीं करेगी, वो ही इफेक्ट करेगी लंग्स में। तो दैट्स व्हाई टेक्निकल पर्सन्स वर नॉट देयर जो कि लाइपोसोम्स बना सके इमीडिएटली। So that's why the shortage was there in the market. So that is the application of nano. Again examples है नैनो टेक्नोलॉजी के। अब कंक्लूजन में आ जाए, अभी थोड़े से चैलेंजेस है नैनो मेडिसिन में। आई टोल्ड यू कि किसी के एडवांटेजेस हैं तो उसके डिसएडवांटेजेस भी हैं। Then AI in nano medicine, AI in drug discovery, time hota, so I could have explained you. Then the target identification and hit discovery, safety. अब बस में कर रही. Then the AI optimist जो बताया उसको थोड़ा सा तो explain. Then the regulatory aspects, I think other scientists will explain you how the role of the regulatory is there. अब मैं कंक्लूजन में आ रही हूँ. So conclusion, the AI enables efficient discovery by predicting optimal formulation and nanoparticles design. Then the digital tools support in silico modeling. As we know that अभी सब in silico करते हैं. अभी जब स्टूडेंट्स M1 में पहुंचेंगे, जो सबसे पहले आपको मॉलिक्यूल मिलेगा काम करने के लिए, पहले आप इन सिलिको स्टडीज कर लीजिए. और उसके लिए जरूरी नहीं है कि आप पैसा खर्च करें, आप डाउनलोड कर सकते हैं. कुछ हमारे फ्री के वो वर्जन्स हैं, सॉफ्टवेयर्स हैं, जो कि आप स्मार्टली उसको सीख के और देन अगर आपको पैसा खर्चना है तो आप बाद में खर्च सकते हैं. Then we are having digital tools. Then the smart nano carriers allow site-specific and controlled drug delivery. Integration of AI with nanotechnology improves therapeutic efficacy and patient safety. These advancements contribute to personalized and precision medicine, transforming traditional drugs. Now, in the last, thank you all listening. uh, and again, my sincere thankful to Maharish Yogi University to given me a chance to this platform, and I'm thankful to my co-partner, Smriti Ahusha, chairing the session. So thank you all.
Before concluding the session, I would like to ask from the audience if you have any question
Yeah,
or any view you want to share.
because the other scientists हमारे वेट करते हैं, उनको जाना भी है किसी सब्जेक्ट में, आप लिख लीजिए और फिर मेरे से बात में आप.
Ma'am is so polite. Okay, on behalf of everyone present here, I extend my heartfelt gratitude to Dr. Kanchan Kohli ma'am for her enlightening and inspiring session. We sincerely thank our esteemed speaker, Dr. Kohli ma'am, for delivering such an insightful and thought-provoking expert talk on AI and smart pharma in drug discovery. Ma'am, you have explained very well how this AI integrated research can reduce time, cost, and chances of negative results too. We look forward to your continued guidance and support, mentorship in years to come. Thank you so much, ma'am. Thank you for being here.
Thank you, Dr. Kanchan Kohli ma'am, and thank you, Dr. Smriti Ojha ma'am.
May we now request our respected chairperson, Dr. Smriti Ojha ma'am, to kindly felicitate the esteemed speaker, Dr. Kanchan Kohli ma'am, with a memento, certificate, and conference kit as a token of our gratitude and appreciation. Please put your hands together for Kanchan Kohli ma'am. With immense pleasure, we request Dr. Shashikant Singh Sir, Principal, Faculty of Pharmaceutical Sciences, kindly come forward and present a memento, certificate, and conference kit as a token of appreciation to the chairperson, Dr. Smriti Ojha ma'am. Please put your hands together for Dr. Smriti Ojha ma'am.
Thank you, ma'am. Thank you, sir. After session first, we proceed to technical session second. Digital health tools, potentially implication in context to management of tuberculosis. It is my privilege to welcome Dr. Sanjay Tiwari, sir, professor at Naipar Library. The session is chaired by Dr. Alok Kumar Das, sir, professor Triple MUT, Gorakhpur. Please put your hands together for Alok, sir.
A warm afternoon to all of you. Distinguished dignitary and the dais and wonderful gathering present here, I take the opportunity to introduce our highly esteemed speaker, Dr. Sanjay Tiwari, sir. Dr. Sanjay Tiwari, Professor and Head, Department of Pharmaceutical Regulatory Affairs at Nayan, Raebareli, Uttar Pradesh. He is recipient of prestigious Fellow of UGC ICMR. He received Gandhian Technological Innovation Award. His PhD work on tuberculosis. He has secured research grants from agencies including EGC, DAA, and Gujarat CST. He has authored more than 85 research review articles in leading journals, drug delivery, and collateral sciences. With great pleasure, asserting the introduction, I invite our respected speaker, Dr. Sanjay Tiwari, sir, to kindly come forward and enlighten us with his wonderful wisdom. Please, sir.
So, thank you very much, Dr. Das. I have got 15 minutes minus the formalities, minus the disturbances that I may have from the backbenchers, right? So please let us not have those many formalities. I'll straight away go to what I have to do today. So I would like to thank the organizers, particularly Sudhanshu Mishra, for having me here. And I'm here to talk about the the role of digital health tools in the management of tuberculosis. So tuberculosis is connected to every one of us. Uh, there is no boundary that this disease recognizes, and I have done my PhD on this particular topic. So when this opportunity came to me about talking in this conference, this is the topic that I picked up. And so 70% of the lecture will be focused on the discussion on tuberculosis, and 30% will be covered on the management, the role of management of the tools that we have, digital tools in the management of tuberculosis. So this is one of the center of WHO, which they have set up to manage tuberculosis. It looks very clean when you look at the outside, but when you look inside, this is what you see. These are the people, they are living. People talk about the deaths which are related to cancer. Please don't disturb. Those who are not interested, please go outside, right? So people talk about cancer, and they talk about cancer because cancer causes death. With best of the treatments that we have available, the overall survival rate is 2 to 5 years. Regardless of what you do, the overall survival rate is 2 to 5 years. In tuberculosis, patients do not die, patients live. Patients will live with this disease until they reach to this condition. They begin as a carrier, and then they become active cases, then they become XDR, they become MDR, and then the treatment options that we have, these are very limited, and the people, they sometimes they are reduced to such skeletons. So it affects the people of all ages. This is a problem. Yes. So it affects the people of all ages, and there are, 1.3 million deaths which is happening. This is a very old, data, right? So these many deaths, and then you see This is considered to be a social stigma. People, if you expose yourself of being a patient of tuberculosis, people they prefer to stay away from the patient. That is the very problem with this disease. So if you look at India, these many deaths are happening each year, and then this is happening because of inaccurate. Sometimes it is related to diagnosis, sometimes it is related to the treatment. Sometimes treatments are available, sometimes support is available, the patient is non-cooperative. Okay, so we'll discuss the reasons why patient is non-cooperative and what can be done to make them cooperative, to make sure that they complete the overall course of treatment. So relapse is very high because the bacteria develops resistance, and resistance to virtually all the drugs that we have available, and relapses are too high. So what can be done about preventing the relapse? So what you can do is, the patient who is under treatment, the patient has to be monitored by screening of chest X-ray and then the liquid culture every week. You can go for giving a sputum, and then they do culture, and then they see the conversion of sputum from positive to negative, and that's how you detect the cases. Now, whenever it comes to diagnosis, we are so lazy. People are so lazy, right? Whenever you go to doctor, he will write the test, and then the moment you see the list of tests, हमेशा ऐसा लगता है. When the doctors who are known for their charity work, उनको भी हम क्वेश्चन करते हैं कि इसने इतने सारे टेस्ट दे दिए, हम टेस्ट के लिए जाते हैं, हमने पैथोलॉजी में रिपोर्ट दे दी, अब टेस्ट सारे सपोज करो नेगेटिव आ गए, आपको उसने 50 टेस्ट दिए और 50 टेस्ट नेगेटिव आ गए, अब हमारा रिएक्शन क्या होता है? वो 5,000 रुपए हमने लगाए, सारे वेस्ट हो गए. वेस्ट क्यों हो गए? बिकॉज सारे टेस्ट नेगेटिव आए. विच मीन्स व्हाट वाज इन योर माइंड कि 5,000 लगा रहा हूं तो सारे टेस्ट पॉजिटिव आने चाहिए. We should be positive for TB, we should be positive for AIDS, we should be positive for this, we should be positive for that. Okay, and then whenever it comes to follow up, nobody takes care of follow up. डॉक्टर ने आपको 5 दिन बाद बुलाया और हमेशा आप 500 की फीस बचा लेंगे आप. And this is the reason we have relapses, this is the reason we have tuberculosis, and then it is killing people, it is affecting a lot of people. So in majority of the cases, lungs are affected, but sometimes when the lungs get overburdened, it can travel anywhere. Bacteria can travel anywhere. Wherever it finds oxygen, it can go to even to the bones. There are cases. So now there are some more diseases coming up. There is AIDS. Combination of AIDS with TB is so deadly. There is no cure, right? Then half of the population is infected. If we have got 300 people sitting over here, how many are infected? 150. Look around. So there may be active cases, there may be inactive cases. हमारे यहाँ एक्टिव केसेस इसलिए भी डायग्नोज नहीं होते क्योंकि खांसना हमारे यहाँ बहुत आम है. हमारे घरों में, गांव में, जब बड़ा घर से बाहर से अंदर जाएगा तो वो खांसेगा. अगर आपको डिस्ट्रैक्ट करना है तो so this is considered very usual. आप यूरोप में हो, किसी लैब में हो, काम कर रहे हो, वहां आप 2 बार खांसो, the people, your co-workers, they will object. You have the test done. आप 2 दिन खांसो, you will be forced to have the test. But over here, you keep coughing for years and nothing happens. People do not care about it, right? So we should care about ourselves. Doctors, pharmacists, companies, उनको कोई नहीं पड़ी है, हमें पढ़नी चाहिए. So transmission, it happens through coughing, sneezing, shouting, or any other mechanism which allows the bacteria to expel. आपने 10 से 20 bacteria expel किए, in the vicinity there is some healthy individual, inhale किया, it goes to the lung, and then it is able to develop to give you the clinical symptoms. So these many bacteria, 10 bacteria, they are enough. We don't need truckloads. And pathogenesis, will not talk about. Those who are reading pathophysiology, this must be covered, right? So bacteria builds up, it remains dormant until a point, and then when the titer reaches to a certain level, it bursts, and then it is available everywhere. It mobilizes from the lungs to upper airways, and from there it goes to everywhere. Once it is there in the intestine, once it gets through alveoli into blood, it is everywhere. and there is no control. There is no drug which can control. So these are some of the manifestations. First sign that you have from a tuberculosis patient is coughing. Okay. Then together with this, you have consistent fever. It never goes away. You have weight loss. You have weakness. The patient becomes frail. Okay. And then other organ-specific symptoms will appear, and this takes years to develop. Which means, if you see the overall latency, this can be in years. So the drug delivery is inadequate. Drugs are available, but there is a problem with the delivery. There is a problem with the compliance. People do not stick to the schedule. If you are asked to take the drug in the morning before breakfast, before food, you have to take this drug without food. At least you need to have an interval of 1.5 hours. Do we bother about this? Isoniaz, it potentially interacts with food components. If it finds aldehyde, if it finds alcohol, it will interact and then it gets neutralized. You don't have the effect. And that is the reason we have drug resistance. Then there are some programs. We have a program which is ongoing. There are a number of schemes available, right? But some of the programs very inefficient, particularly in developing countries. We have very effective TB program. Then sometimes it is related to the compliance of the patient. This can be deliberate. मुझे दवा नहीं खाना है, मुझे दवाएं पसंद नहीं है, मुझे दवाओं से उल्टी आती है. Those type of non-compliance. This can be sometimes related to failure to understand. You need to patient understand that अगर आपको ठीक होना है, this is the way out. Otherwise, this is going to happen to you. You need to understand. Pharmacists have to understand कि अगर ये ड्रग्स आप नहीं लोगे, इसके क्या कॉन्सिक्वेंसेस हो सकते हैं, ये आपको बताना पड़ेगा, पेशेंट को बताना पड़ेगा. देन दे विल बी एबल टू अंडरस्टैंड. समटाइम्स दे बिकम सस्पिशियस. रिफाम्पिसिन नाम सुना होगा, थर्ड ईयर ऑनवर्ड्स. नाम सुना होगा. व्हाट इज द कलर ऑफ दिस ड्रग? दिस इज ऑरेंज कलर ड्रग. जैसे ही पेशेंट लेगा, ही और शी विल पास ऑरेंज कलर्ड यूरिन. पेशेंट डर जाएगा कि भाई ये क्या हो रहा है, हाउ कम आई एम पासिंग ऑरेंज कलर्ड यूरिन. फार्मासिस्ट का रोल है उसको बताए कि आपको ये होगा, आपका जो यूरिन का कलर है इट विल गेट कन्वर्टेड फ्रॉम येलोइश टू ऑरेंज, राइट. कोई पेशेंट है जो आइसोनियासिस थेरेपी पे है, उसको हमेशा इट डेवलप्स पेरिफेरल न्यूरोटॉक्सिसिटी. ओके, पेशेंट चिड़चिड़ा हो जाएगा. ये इसलिए नहीं हो रहा कि उसको होना है, ये इसलिए क्योंकि ड्रग का ये साइड इफेक्ट है. ओके, this has to be understood by the patient and the caregiver. So sometimes this can be related to alcoholism. Okay, you lose you are always under delirium. Then sometimes this can be related to nursing support. We always have a shortage of staff. So this can also be a reason. How much time I want? Sir, kitna time hai? Bata de rana. So toxicity of the drugs. हम टीचर्स साथ दिक्कत है, जब भी हम बोलना शुरू करते हैं ना, हमें सबसे पहले हमें रोका जाता है, टीचर्स को रोका जाता है. ये अभी मैडम साथ हुआ, मेरे साथ होने वाला है. ओके, सो इंटरेक्शंस, ड्रग इंटरेक्शंस. हाउ मेनी ड्रग्स वी स्टार्ट विद? देयर इज इंटेंसिव थेरेपी, देयर इज कंटिन्यूएशन थेरेपी. We begin intensive therapy with 4 drugs: isoniazid, rifampicin, ethambutol, and ethonamide. Okay, and this is a combination, right? You begin with 4 drugs. Sometimes, if you see if smear conversion is not negative, then you have to add more drug, right? Again, it is problematic. So this can be the reason. There are chances of interaction. अगर patient को TB है, उसके साथ उसको AIDS का भी symptom है, वो इसके साथ diabetic है, then complications grow. You need to understand. Then the drug may be poorly bioavailable. Sometimes this can be reason of interaction. The drug is interacting with food. That can be the reason. Then poor access to macrophages. Macrophages are the targets. They are sitting in the alveoli, okay, and then they are loaded with macrophages. So that is the problem. So what happens? There are drugs available and which are active against the MTB. But whenever these are administered, because of these factors, you do not have enough concentration of drug reaching at the target site, and therefore you develop relapses, you develop resistance. So we begin with 4 drugs, and then if the patient does not cooperate, you can end up to 12 drugs. Administration of 12 drugs. And then if you see the overall course of therapy, this is the multi-story building, 30-story building that piles up. You keep on adding tablets, and then this is the building that you can create with the drugs. Okay, this is the reason of non-compliance. So what happens if you do not follow right schedule? हमारे लिए मॉर्निंग मतलब बहुत वेरिएबल है. मॉर्निंग किसी की 7 बजे की है, किसी की 8 बजे की है, किसी की 12 बजे की है, किसी का अगले दिन की है. संडे, अगर ये संडे है तो हो सकता है किसी की मॉर्निंग 2 बजे हो रही हो. But it has to, you need to follow at the time, right? If the drug is to be taken at say 7 a.m. without food, it has to be taken every day, regardless of if it is Sunday or Monday, right? So what happens if you do not follow the schedule? Either you are under medicated or you are over medicated. Make sure that you are following a schedule which offers you the drug fluctuating within the minimum effective therapeutic concentration. So now here comes the role of Sarkar, the government, the policies, right? So what policies do we have? So there are TB control programs, and then they are aimed at curing the patient through individualized. Okay, so patient can be an active case, patient can be an MDR case, this patient can be XDR case. Accordingly, the patient has to be treated individually. Okay, you need to see the patient individually. Then you have to minimize the risk and the disability, the quality of life. Okay, you have seen those people, those pictures. You think about the quality of life. जैसे आप हम मॉल में जाते हैं, वैसे उनको भी मॉल में जाने का हक है. ये होती है क्वालिटी ऑफ लाइफ. उनको भी इस तरीके की चीजें मिलनी चाहिए, हेल्थ ऐसी होनी चाहिए. देन पब्लिक एजुकेशन, रिडक्शन इन द ट्रांसमिशन ऑफ ट्यूबरकुलोसिस. हाउ? किसी भी पेशेंट को, किसी पेशेंट ने एक्टिव केस है, आपने डोज दिया, 1 मंथ के लिए डोज दिया, पेशेंट बिकम्स नॉन इन्फेक्टिव. कोई डरने की जरूरत नहीं है. विद इन 2 मंथ्स द पेशेंट बिकम्स नॉन इन्फेक्टिव. आपने स्मीयर देख लिया, इट हैज बिकम नेगेटिव फ्रॉम पॉजिटिव. दैट इज द शॉर्ट ऑब्जर्वेशन. देन पब्लिक एजुकेशन एंड कम्युनिकेशन कैंपेन्स. अभी बहुत सारे कम्युनिकेशन कैंपेन्स है. You can see government is doing a lot. Government is spending a lot of money. There is a lot of money coming in from WHO, right? So these programs are in place, and we need to cooperate. We need to cooperate as a patient. We need to cooperate as a caregiver. So now, in case of TB, the responsibility of the treatment usually it has been rested on the shoulders of healthcare provider. अभी डॉट्स प्रोग्राम है, नर्सिंग स्टाफ डॉट्स प्रोग्राम के अंदर नर्सिंग स्टाफ को जाना है, पेशेंट को रिमाइंड करना है, पेशेंट को दवा देना, या फिर ऐसा है कि पीएचसी पे पेशेंट आएगा, उसको आपको डेली दवा देना है और मॉनिटर करना है, डेली ट्रीट करना है कि इससे आप 2 दिन पे दवा लेनी थी, इससे इस टाइम पे लिया या नहीं लिया. ओके, एंड देन यू हैव टू कलेक्ट स्मीयर, यू हैव टू कलेक्ट द स्पेसिमेन, कल्चर जो भी है उसको टेस्ट करना है, राइट? सो दिस प्रोग्राम्स आर देयर. So this is the dots. We have already discussed the essential features of dots. So this detection is based on smear microscopy. Then there is availability of standardized treatment, intensive therapy, and then this is followed with the continuation therapy. The government is ensuring that there is continuous supply, continuous uninterrupted supply of the drugs, or these drugs are available free of cost. India as a country, considering our economic conditions, we are still supporting these programs, TB elimination programs. This has to be appreciated. Then recording procedure. Okay, you are collecting data, and then you need to have a record of every patient. Okay, and these stories need to be told to everyone that ये patient था और ये convert हुआ. This has happened to my family, my own family. Okay, people they contacted tuberculosis, and they could be treated because I acted as a responsible pharmacist. My friends, they got contacted with TB of backbone, and they could be treated because they followed the schedule. They understood that if you take the drugs, I can be treated. This is the only way I can live. Right? So if you provide support, patients, they will cooperate. So There are challenges, but still this program is ongoing, and then this has it is getting success. People are talking about it. Doctors are very serious. Nursing staff is becoming serious, right? क्योंकि अपने इंडियन सेटअप में सिर्फ एक बंदा बीमार नहीं होता है. जब दादा बीमार होते हैं तो दादा के साथ में हर कोई बीमार होता है, क्योंकि उनकी सेवा में 25 लोग चाहिए. ये चीज यूरोप में नहीं है. जो बंदा बीमार हुआ वो हॉस्पिटल जाएगा, खुद से वहां एडमिट हो जाएगा, वहां सपोर्ट स्टाफ है, ये है वो है, पॉलिसीज हैं टू सपोर्ट हिज मेडिकल एक्सपेंसेस. ये चीज अपने यहाँ नहीं आएगी. अपने यहाँ एक बंदे को अगर स्टेशन छोड़ना है तो 25 लोग जाएंगे स्टेशन छोड़ने के लिए. ओके, नाउ कमिंग टू द रोल ऑफ डिजिटल adherence tools. There are number of digital tools which can send you reminders. आइडियली क्या होगा, अभी जो प्रोग्राम है उसमें क्या है, पेशेंट का स्मीयर हमने लिया, एंड देन वी सस्पेक्ट दैट दिस इज एक्टिव केस, वी बिगिन द ट्रीटमेंट. ओके, एंड देन देयर इज अ प्रोग्राम अंडर विच द पेशेंट विल रिसीव अ कॉल राइट एट 7 AM. सुबह 7 बजे उसको कॉल आएगा कि आपके दवाई लेने का वक्त है और दवाई खाली पेट लीजिएगा. इससे ज्यादा कोई क्या कर सकता है. Okay, now the patient has to respond. Now the people in the vicinity, they have to respond. Family has to respond, right? So there is SMS surveys. Then there are video observed therapy. This is not available at our place, but yes, this is being done in advanced countries, developed countries. Then there are medication monitors. अगर कोई मिस डोज हो गया, हमारे यहाँ क्या है कि हम हर चीज को कॉस्ट से रिलेट करते हैं. एक डोज अगर मिस हुआ, जस्ट 2 मिनट्स. एक डोज मिस हुआ तो हम उसको कवर करने के नेक्स्ट डे दूसरा डोज लेंगे, दो डोज लेंगे. ओके, राइट, दिस शुड नॉट बी डन. वी हैव टू अंडरस्टैंड. देन देयर आर फोन बेस्ड एंड देन डिजिटल पिल बॉक्सेस विल रिमाइंड यू. अलार्म बज जाएगा कि आपके दवा खाने का टाइम हो गया है, आपके खाने का टाइम हो गया है. टीबी में आपको दवा भी ठीक से टाइम पे खाना है और खाना भी ठीक टाइम से खाना है. अभी का जो प्रोग्राम है उसमें गवर्नमेंट आपको दवा भी दे रही है और खाने के लिए आपको 1000 रुपीज पर मंथ आपको दे रही है, सपोर्ट दे रही है. ओके, दिस इज व्हाट गवर्नमेंट इज डूइंग, राइट? सो there are such tools which remind you about your medications. Then you have such tools, SMS, and then there is a pill box, right? Pill is over here. Now you can count the pill कि आपको 30 दिन का डोज दिया गया था, उसमें से आपने सारी उस 30 दिन में लिया है कि नहीं लिया है. ओके, then there are ingestible sensors. We are not using these sensors a lot, but yes, these are in the market. Then we have elimination program, NPP, and then the target was to have TB free India. We have polio free India. Okay, how are we going to achieve this TB free India unless we get sensitized? So you have to detect, treat, prevent, and build. And these are the initiatives. There is Nikshay Mitra. There is there is a website. Okay, so they collect all the data about the patient. They share the stories. These programs are already there. There is again one program that allows you 1000 rupees per month to support your nutritive cost. Then finally, if you have to treat tuberculosis, you need to find, treat, cure, track the progress, and then you need to find newer tools of diagnosis and the treatment of latent infections. These are always problematic. They remain latent. They may remain latent for 10 years, 20 years, and they may emerge. And then you need to share the success stories, the stories that I shared. So I just talked. These are the people who hold pipette for me. These are some of my students. I have a team of around 20 students. So some of them are working in cancer and then different areas. So I acknowledge their support and thank you. If there is any question, please, if you have any questions, please do not ask now. We don't have time. Find time during lunch, okay, and we'll discuss. Thank you.
Thank you, sir, for a wonderful talk. As you know, amantramaksaram nasti, nasti mulana avasadaha, ayogya puruso nasti, yukistasar durlabha. Sanjay sir, enlightening us to boost our energy in this conference, and people like him always come to this conference and boost us and have explored knowledge in TB. Thank you, sir. Thank you a lot.
Thank you, Dr. Sanjay Tiwari, sir. And thank you, Dr. Alok Das, sir.
To honor the valuable contribution of our distinguished speaker, Dr. Sanjay Tiwari, I request Dr. Pawan Kumar Gautam, Principal, BRD College of Pharmacy, to present a memento, certificate and conference kit.
Please put your hands together for our honorable speaker.
We cordially welcome Dr. Amit Upadhyay, Assistant Professor, Faculty of Pharmaceutical Sciences, to present a memento, certificate and conference kit as a token of gratitude and admiration to the Chairperson, Dr. Alok Kumar Das.
Thank you, Dr. Pawan, sir. Dr. Alok, sir. We would like to extend our sincere appreciation to all the dignitaries, speakers, delegates, faculty members, organizing committee members, volunteers, and all the participants for their excellent coordination and cooperation through this session. We shall now take a break for lunch. The proceeding will be resumed thereafter with the next session as per scheduled program. We kindly request everyone to reassemble on the time for continuing to conference. Thank you, everyone. One more announcement. जिन्होंने भी ओरल प्रेजेंटेशन में पार्टिसिपेट किया है वो अपना पीपीटी काउंटर पे जाकर के कृष्णा गुप्ता से कन्वे कर लें वहां पे रजिस्ट्रेशन काउंटर पे पोस्टर प्रेजेंटेशन ऑल्सो